Hello, everybody. This is Rob Pass, the host of the podcast. I hope everybody enjoys this week's replay episode all about troponin. We'll be back next week with a brand new episode.
Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I am professor of pediatrics at the Icahn School of Medicine at Mount Sinai, where I'm also the chief of pediatric cardiology. Thank you very much for joining me for this 251st episode of the podcast. I hope everybody enjoyed last week's episode 250, on the topic of mental health disorders affecting patients who have chronic disease. We spoke with Dr. Vincent J. Gonzalez, who's an adult congenital heart fellow at Texas Children's Hospital. And for those of you with an interest in mental health issues, as well as the concept of poverty and race as it affects healthcare delivery, I'd recommend you take a listen to last week's episode 250. As I say every week, if you'd like to get in touch with me, my email is easy to remember. It's pediheart@gmail.com. This week we move into a very interesting work. The title of the work is Myocardial Injury Thresholds for 4 High-Sensitivity Troponin Assays in a Population-Based Sample of U.S. Children and Adolescents. The first author of this work is John McEvoy, and the senior author Elizabeth Selvin. And this work comes to us from the University of Galway and National Institute for Prevention and Cardiovascular Health in Galway, Ireland. When we're done reviewing this paper, the first author, Dr. McEvoy, has graciously agreed to join us all the way from Galway, Ireland. Therefore, let's get straight onto this article and then a conversation with its first author, Dr. McEvoy. This week's work is on the topic of cardiac troponin levels, and specifically high-sensitivity troponin levels. Some may recall that about 5 to 10 years ago, most hospitals moved to high-sensitivity assays for troponin as an indication of myocardial injury due to the more precise measurement capability of this test, and the fact that the technique has a more precise measurement at a lower concentration. High-sensitivity troponin assays have a much higher sensitivity for acute coronary problems than conventional assays, which yield a much higher negative predictive value. This allows clinicians to more quickly and accurately identify those chest pain patients who do not have an acute coronary syndrome and who are at very low risk of 30-day major adverse cardiac events. However, troponin testing in pediatrics is less common than in the adult world, and in most of our patients, the troponin is not elevated for things like infarction, but more commonly for things like myocarditis or as a result of injury, such as from medicines like those used for some cancers. The authors explain that traditionally a troponin level that's above the 99th percentile for a healthy reference population, or the so-called upper reference limit, is the definition of myocardial injury. And they explain how the 99th percentile upper reference limit has been the benchmark for troponin assays to suggest myocardial injury in the adult. However, the authors mention that there are no formal recommendations or guidelines for myocardial injury in children and adolescents, and they further explain that most reports using high-sensitivity troponin levels use these same thresholds, and they wonder about the generalizability of these values to children in the U.S. population. The authors then speculate that because myocardial infarction is uncommon in children, maybe the 97.5 percentile upper reference limit of high-sensitivity troponin might be more relevant than the 99th percentile, and explain that for most other tests in medicine, the 97.5 percentile is actually the threshold for what we consider abnormal. With this as a background, the authors explain that they measured 3 different high-sensitivity I assays and 1 high-sensitivity troponin T assay in stored serum samples from people 1 to 18 years of age who participated in the 1999 to 2004 National Health and Nutrition Examination Survey, or NHANES study, with the aim of describing the distribution of these values, as well as the 97.5 percentile and 99th percentile upper reference limits of high-sensitivity troponin in healthy U.S. kids, and also looking at differences that might exist based on sex, race, or ethnicity and age. This was a retrospective review of serum samples that were about 20 years old from the time frame I described, and these were stored at minus 80 degrees centigrade from 5,695 non-pregnant patients 1 to 18 years of age, with data on their high-sensitivity troponin values. The authors performed analyses in 2 samples, a healthy reference subsample of patients 1 to 18, and then the entire group, allowing for generalizability to the U.S. pediatric population. They review how the serum samples were measured from thawed specimens and how they used 4 high-sensitivity assays on these specimens. The authors explain in Figure 1 how they determined who should not be included, and these included patients with obesity, those on medications that could lower lipids, as well as those on medicines that can affect the level, patients who had diabetes, those who had hypertension, smokers, and those who had renal dysfunction. And so in the end, the healthy reference sample had 4,029 patients, which seems quite robust, with a mean age of 12.6 years, and 50% were male. And on to the results. Well, there are a lot of important findings in this work, but let me summarize them, and as usual, I'd recommend you consider reading this paper for the details. The first important finding was that the 99th percentile upper reference limits for all 4 high-sensitivity troponin assays assessed in children in this study were lower than the manufacturer's reported upper reference limits for adults. I'm not going to go through what the exact values were at the 99th percentile for each of the 4 assays, but the tests used were quite standard, and these were the Abbott assay for troponin I and troponin T, the Siemens assay for troponin I, and finally the ortho assay for troponin I. Thus, 3 different manufacturers' troponin I assay and 1 for T. Again, I'd recommend that you read the paper for the precise upper reference limits for these values for each of these different tests, but suffice it to say that all were lower than the adult reference values, and they were all different between one another. Second, for all 4 assays tested, there were differences in the 97.5 percentile upper reference limit when comparing male and female children and teenagers, meaning differences between boys and girls, and the authors note that the distribution for high-sensitivity troponin levels were shifted to the right when comparing male versus female youth in this healthy reference group. Third, there were some differences in the values between those less than or equal to 7 years and those 13 to 18, and the 95% confidence intervals for the 97.5 percentile upper reference limit did not overlap for the high-sensitivity cardiac troponin T or I in the Siemens analyses. Fourth, amongst female children, there were no differences in the high-sensitivity troponin assay in the 75th percentile, 97.5 percentile, or 99th percentile upper reference limits for each high-sensitivity troponin assay. However, amongst the male children, when comparing the youngest and the oldest T or I assay performed with the Siemens assay, there was no overlap between the 95% confidence intervals for the 99th, 97.5 percentile upper reference limits, but there was overlap between the 2 high-sensitive I assays. Importantly, there were no differences seen amongst the 4 assays when looking at race or ethnicity. The authors then did sensitivity analyses looking at the 99th and 97.5 percentiles and basically determined that the upper reference limits were quite stable at the 97.5% upper reference limit, but not at the 99th percentile, meaning that the point estimates of the 97.5 percentile pediatric upper reference limits for troponin were more stable to differences in the analytic approach taken to estimate the upper reference limit, and perhaps in that way were more reliable. In their discussion, the authors state, and I quote, "These analyses provide the new 97.5 and 99th percentile upper reference limits for 4 different high-sensitivity troponin assays derived from a single common reference group of healthy children and adolescents sampled from the general U.S. population. Consistent with a number of previous reports and smaller selected samples, we found that 99th percentile upper reference limits for high-sensitivity troponin derived from a subsample of healthy children and adolescents participating in this study were significantly lower than the 99th percentile adult upper reference limits in clinical use. We did not find significant differences in the 99th percentile upper reference limits by sex, age, or race and ethnicity. We observed differences in the 97.5 percentiles for each cardiac troponin assay by sex. The 99th percentile upper reference limits were much less precise than the 97.5 percentiles in our study population, and the point estimates for 97.5 percentile upper reference limits were also much more robust to the methodological approach to percentile estimation and outlier removal. The authors then explain that their work has shown greater degrees of precision to the 97.5 percentile than the more traditional MI level of 99th percentile, and that despite different analytic approaches, the values are still more stable at the 97.5 percentile. They explain that they believe that these results should challenge the use of the 99th upper reference limit for children in diagnosing myocardial injury, and how the 99th percentile was chosen in adults to minimize false positives in the diagnosis of myocardial infarction. But given the rarity of MI in kids, troponin is more likely due to injury from other factors like inflammatory disease, and they state, and I quote, "As such, the more stable and precise and more sensitive 97.5 percentile upper reference limit may be a better threshold among children and adolescents, and indeed the 97.5 percentile upper reference limit is the common threshold for abnormality in other lab analyses in pediatrics." They explain that smaller studies have suggested that 97.5% should be utilized, and that this work with a much larger data source confirms this. They mention some limitations, including the use of the ortho assay, which is not presently available clinically in the United States, the use of frozen specimens and what that might do to specimen values, the use of serum versus plasma for testing and how this may affect values in an unknown manner, the absence of data on children under 12 months of age, and very few between 12 and 24 months, which were only 37 patients in total, the fact that patients with elevated CRPs or other inflammation may have been included, and this may have affected the levels as well. And so they conclude, in conclusion, 99th percentile high-sensitivity troponin upper reference levels in this subsample of healthy children and adolescents participating in the study were significantly lower than the manufacturer-reported 99th percentile upper reference limits in adults and did not differ on the basis of sex, race, and ethnicity or age group. However, the 99th percentile high-sensitivity troponin upper reference levels were estimated with low statistical precision and varied on the basis of analytic approach. Given that myocardial infarction is rare in children and adolescents, our results support the use of more stable and statistically precise sex-specific 97.5 percentile upper reference limits in the assessment of pediatric myocardial injury. Well, this is certainly interesting in that it provides what are likely new standards of high-sensitivity troponin to be used when assessing children for myocardial injury. That the values are routinely lower in children compared to adult standards is important in improving the sensitivity of this testing, and I think it's interesting how lowering the upper reference limit may improve the statistical robustness of this value, and I'll be honest in needing some schooling from Dr. McEvoy on this point. I think the fact that the values are different in different assays is also of concern, as I don't ever recall inquiring clinically as to what assay my particular hospital is using, and it seems from this that this is an important factor. I also wonder about these differences between girls and boys at the 97.5 percentile, and whether that should be clinically important in using these values. There's much to discuss, and so in the interest of time, let's move on to our conversation with the work's first author, Dr. McEvoy. Joining us now to discuss this week's work is its first author, Dr. John McEvoy. Dr. McEvoy is Professor of Preventive Cardiology at the National University of Ireland, Galway campus, and is a consultant cardiologist at University College Hospital, Galway. He also serves as Medical and Research Director of the National Institute of Preventive Cardiology. Professor McEvoy is a 2004 first-class honors graduate of UCC School of Medicine in Cork, Ireland. Professor McEvoy's research focuses on testing novel biomarkers of risk and comparative effectiveness research, with an emphasis on hypertension and atherosclerosis. It is indeed a great honor and privilege to have him join us this week on the podcast. Welcome, Dr. McEvoy, to Pediheart.
I'm here now with Dr. Bill McEvoy. Dr. McEvoy, thank you so much for joining us all the way from Ireland today.
Hi, Robert. It's a pleasure to be here.
Thank you. Congratulations to you and all of your co-investigators on a wonderful paper, very practical and important. Before we move forward, Bill, I wanted to ask you, most pediatricians, which of course most of the listeners of this podcast are pediatric cardiologists, don't know as much about troponin levels as maybe we should. Could you give us sort of a basic understanding of the differences between a high-sensitivity troponin and a regular troponin level, and why the change was made to this approach, and were there many instances where patients were missed with the prior assay? And in similar vein, maybe you could comment also on the difference between measuring troponin I versus T.
Okay. I'm an adult cardiologist, so we use troponin every day. In terms of the newer generation of high sensitivity assays, those were developed to facilitate more early diagnosis of myocardial infarction. And their defined characteristics for a high sensitivity assay that are well established. A high sensitivity assay must be able to measure detectable troponin value in greater than 50% of a healthy reference population. And in the 99th percentile of that healthy reference population must be at a value that is less than 10% of the coefficient of variation for the assay. So if you were to repeat the test, you'd get a result that's within 10% of the first test. So they're sensitive and reliable, even down to small concentrations. Again, 50% of normal people will have detectable values. The rationale largely was to facilitate early diagnosis of MI, because, as you know, in the past with the older assays, we had to wait in some instances for 8 hours, particularly for patients who are presenting early with chest pain. With these assays, it's facilitated in adult medicine protocols that allow for even a 0 and 1 hour diagnostic algorithm for MI. And so that's really where this high sensitivity troponin assay came from. The assays, because they're so sensitive and because they detect values in healthy persons, 50% of the healthy reference population, they've also found a place in prognostication in adult medicine. They haven't really penetrated into clinical practice yet in terms of prognostic biomarkers, but that's certainly where a lot of research direction has gone, and that's my own interest as well in these assays. The older assays obviously were less sensitive, and so you had a coefficient of variation of 10% that was at a higher concentration. So you were less sure about a value, and you may have missed cases of MI, particularly in early presenters, and had to wait and repeat the test. I don't think that the assays have proven to be hugely different in terms of clinical outcomes. There have been studies looking at this, stepped cluster trials to look at the implementation of these assays. And I guess the jury's still out as to whether or not patients benefit from this more early diagnosis of MI and from the potential for more early and swift triage. And so that's something that needs to be emphasized. But nonetheless, they have been FDA approved. They're in use across the US. They've been in use more broadly in Europe for many years. And we have them in our hospitals, so we need to know a little bit about the differences between the new versus old assays.
The last question I had was about a troponin I versus T.
So as you know, troponin has 3 subunits, T, I, and C. The T and I subunits are cardiac specific. The C subunit is not. And so we only look at T and I when we're trying to look for myocardial injury. The T assay has a patent, so only one vendor makes T assay, whereas the I, there's a number of vendors that produce assays to measure troponin I. Overtly, they should be very similar. You'd imagine a myocyte that is injured or that necroses will release both T and I and C into the bloodstream, and so we should see similar results. There are slight differences in the assays in terms of their capture and detection antibodies and their sensitivities. None of the assays are actually standardized to each other. In adult medicine, there have been some data to suggest that the T assay may be more closely linked to all-cause mortality, and the eye assay may be more closely linked to cardiovascular disease outcomes. And some of the thinking behind that is that the T assay may be expressed, or the troponin T may be expressed from diseased skeletal muscle, and that may be detected even with this cardiac-specific assay. And so we know from studies of patients with myopathies, Duchenne's muscular dystrophy, maybe this is relevant for you in the pediatric world, that there are higher values of the high sensitivity troponin T in patients who have myopathies and muscular diseases than in the troponin I assay. So there may be a little bit of overlap between the myocardium and the skeletal muscle, particularly when the skeletal muscle is very diseased for the T assay. The eye may be more cardiac specific. For most intents and purposes, they're both very cardiac specific, must be emphasized, and they're both used fairly interchangeably. Our hospital here uses a T in Galway, whereas the next hospital over, where we get a lot of transfers, uses an eye. Actually, that creates some issues because you have to be able to interpret the differences between these assays, and it's not always straightforward.
I see. Well, I would think having you there might make that a little easier as an expert on troponin.
I keep on reminding people that they're not standardized. So a value of 1,000 in one, and then coming with an I, and then coming to this hospital and having a troponin of 100 with a T, doesn't mean your troponin came down.
I see. Interesting. You know, Bill, in your work, you suggest that using high-sensitivity troponin assays at the 97.5 percentile should probably be used as what we would think of as abnormal in children rather than the more standard 99 percentile that's used in adults when making the diagnosis of MI, and suggests that the coefficient of variation is low at the 97.5 percentile, suggesting more reliability. For those statistical morons in the audience like myself, I'm wondering if you could explain to the audience why you suggest that a value of 97.5% be used rather than 99% when speaking of children.
Yeah, so for most lab assays, the 97.5th percentile is used as the cutoff of abnormal. So, you know, the process, and I've worked a little bit with this research about the process of defining reference intervals or normal intervals. And that entails taking a sample of healthy reference persons, either adults or children, and measuring the lab analyte in that sample, and then describing the distribution in the sample. And for most analytes, a value above the 97.5th percentile is considered high. Troponin's a little bit of an exception to the rule. There may be others. I'm not actually aware of any other lab analyte that uses a 99 percentile. So troponin is a bit of an outlier there. And that's a concept that has come from adult medicine. And it has been historically motivated too. The two reasons why a 99 percentile has been used in adults is, number one, myocardial infarction is really what we're looking for in adults in most cases with troponin. And as you know, with a myocardial infarction, we tend to see troponin values that are very high orders of magnitude above what you'd see in a healthy person.
Yes.
But you don't. There's some motivation not to have false positives by having a 97.5th percentile. So you'd have 2.5% of persons who are labeled as having myocardial injury in the workup of myocardial infarction in adults would actually be labeled as having myocardial injury despite being in a normal range if you use the 97.5 percentile. So in adults, that 99 percentile was chosen in part to reduce the amount of false positive, to be sure that this person was abnormal. The other element that was historically motivated here around this 99 percentile was that the older assays, their coefficients of variation, their analytic reliability was only in the order of 10 to 20% at a 99 percentile. And if you chose a 97.5th percentile, you would, with the older assays, you would be less reliable and less sure about that value. That's different now with these high sensitivity assays. And so, obviously, in a pediatric population, we were interested in reporting both the 97.5th and the 99 percentile upper reference limit. And that had been studied before, by the way. We didn't come up with this idea of looking at a 97.5. As I said, it's been used for all other analytes, and it's been studied before for troponin in kids. Mm-hmm. So we looked at this, and it was very clear, and this has been described as well, that the 99 percentile is quite labile. It's quite variable depending on how you choose to estimate it. If you use a parametric versus a non-parametric statistic, if you choose to remove values that you think are outliers because they're so high that they're not consistent with a healthy sample, or if you choose to leave those values in your distribution, it can really affect quite significantly the estimate for a 99th percentile. That's been described in adults as well, by the way. So this 99th percentile, I kind of think of it as a little bit of a ghost, depending on what view you take and how you approach your work, you will get a slightly different value, or sometimes actually more than slightly different. Whereas the 97.5 percentile is quite stable, irrespective of how you approach the analysis. And that's partly to do with the reason that you choose a 97.5 percentile, you're going more into the normal curve. And the normal curve is where things tend to always even out. At the tails, things can be a little bit more unreliable. So that had been described before in adults. We were able to show this in kids, that the 97.5 percentile, irrespective of how you chose to do your analysis, irrespective of how you chose to handle outlier values, what statistics you used, you generally got the same value each time. Multiple sensitivity analysis, the same value. Whereas with the 99 percentile, quite labile, quite changeable. And so that was one thing that struck our eye when we were looking at these data. The other thing to note is that with the newer assays, we have coefficients of variation of 10% for values at the 97.5 percentile for most of the assays. All of them were less than 20%. So you still have analytic reliability down at that 97.5 percentile, whereas with the older assays, you would not have had that type of coefficient of variation. So a little bit more assurance in terms of the reliability of the result from an analytic point of view. Also more reliable, like I said, from a statistical point of view. And then we felt that perhaps the logic of applying a 99 percentile for defining abnormal troponin for the purposes of diagnosing myocardial injury, that logic may not apply as well to kids as it does to adults.
I see.
Considering myocardial infarction for most kids, we're maybe thinking about other types of myocardial injury and ones that can be more subtle. So that's where we came to with our conclusions, that there's certainly a lot to be considered, or there's a fair amount of justification for considering a 97.5 percentile. Again, recognizing that that's a kind of standard cut point for abnormality for other analytes.
Yes. Well, that was really helpful. Thank you so much. I mean, I think that was one of the most important points of your paper, so that really clarified it very much. Thank you, Dr. McEvoy. Given that you've identified now differences in abnormal for different types of assays, and even between girls and boys, I'm wondering if you feel that at this point, now that you've published these data, do you believe that the data you've presented are strong enough to warrant sort of a rewriting of what's the normal reference ranges today? And should we have different reference ranges for girls versus boys? And I also wondered if you mentioned in the discussion of your paper that the sample storage might affect the absolute values. So are we able now to use the values that you describe as our new normal, or is there more work that needs to be done before we can do that?
I think that's a great question. I think that the current reference values or normal intervals for troponin that are in use are largely taken from adults, and are often applied to children where troponin is measured. I understand that in pediatrics, troponin isn't as commonly measured as it is in adult cardiology, like in my day job, but where it is measured, typically the lab will report the interval from what's provided by manufacturers, and that's often intervals that are derived from adults. So in that context, here we have data from children and teens. Remember that these are data derived from NHANES, which is a real strength here. You mentioned the 97.5th percentile and 99th percentile and how that's an interesting and important aspect of the analysis, and I would agree. But actually, probably the most important part of this study is that it derives from NHANES. And so the sampling of those participants was designed to be representative of the US population. Most other studies sample people on a convenience basis. Somebody who's coming into your clinic or somebody who's having blood donations, et cetera, et cetera. You almost never see, I'm not aware of any other study where we have kids and teens that are sampled from the general US population. So that's something to emphasize as well. So I do think that these data are superior to what is commonly used at present. So in that regards, I think there's a strong argument to be made to implement these data. Whether or not the 99th percentile is used or the 97.5th percentile is used, I think should be left up to local labs and cardiologists. We make a case for the 97.5th, but I'd recognize that the 99th percentile is already a kind of established cut point in adult cardiology. So I think there's a discussion to be had at the local level around that. In terms of prior data in pediatrics for troponin, and there have been some prior studies, and in some labs they may actually use those prior data, but I think most labs use the manufacturer's data, which is adult. But there have been prior studies, so you can make the case, is our data better than prior data in pediatrics? And I think there again, probably we could argue that we have an edge from NHANES. The prior pediatric samples or convenience samples of kids attending outpatient clinics or hospital care clinics, and arguably they don't represent the general US population. So in that regards, I think we have an edge. It's also far larger. Our sample is far larger than any other prior pediatric sample. We had over 4,000 healthy kids. And I've become a little bit more read in pediatric cardiology lately. But to my understanding, the biggest prior study of troponin reference intervals in kids was in 800, 900 kids. So we have a bigger sample. The other data that have been published have also been published from stored frozen samples. So again, our data in that regard don't differ from prior publications. But I think given the larger sample size, given the representativeness of the sample, I think there's a good case to be made for implementing these data, certainly relative to manufacturer intervals, which are derived from adults. The question about storage, long-term storage, is one that I think is, you could argue pro and for and against. The research would indicate that long-term storage of troponin is stable, but I would also acknowledge that there hasn't been a lot of rigorous research in this area. We have a sample not just of kids and teens. We have a separate paper coming out on these 99 percentiles and 97.5 percentiles in adults. So, like in total, 12,000 or more persons, and that volume or that sample, that amount of participants with stored samples, and over 10 years of freezing, I don't know if that's ever been really looked at. Obviously, we can't go back in time and measure the troponin from when it was drawn in these people, so it's a bit of an unknown. But what I can say is in studies, lab studies, 20, 30 people, that troponin I and troponin T are considered to be stable, even at 10 to 15 years.
Got it.
Look at some papers, they will say, maybe in the space of 3 to 5 years, you might see a reduction in the absolute value in a decimal, like less than 1 nanogram per liter. So I don't think it's going to hugely affect these. And again, in the context of what's out there, what the alternative data are, I think these are arguably better. And in that context, there's a good case to be made for implementation.
Great. Well, for those in the audience, this is the middle of the day for Dr. McEvoy, so I'm going to wrap it up with this final question because I'm sure he's quite busy. The different racial groups studied seem to have similar upper reference limits, suggesting the absence of differences based on race in kids. I'm wondering if you could speak to what differences exist in adults in regards to race and how this may inform clinical practice, and whether you were surprised that there were not differences in racial groups based on what you know in adults.
Yeah, well, I wasn't surprised, and the reason I'm not surprised is that, and it's a good thing to discuss here, when you're choosing to do reference range or intervals normality, you have to sample from your study a subgroup of participants that are defined to be healthy, and those criteria are actually very rigorous. If you look at our methods section, and these are criteria that have been set forward in clinical lab guidelines. So you have to take a sample of people that aren't overweight, they have no comorbidities, they're not on any medicines, they're pristine in terms of their health. And I think when you compare across ethnicities and race groups amongst individuals that are healthy, the fact you don't see differences probably isn't too surprising. Obviously, much of the differences we see, certainly in adult medicine relating to race and ethnicity in cardiovascular disease outcomes, relates to disparities that are explained, at least in large part, by differences in the distribution of risk factors, weight, diet, geography. And so I think if you're kind of comparing apples and oranges in terms of the risk factor profile of these people, I think if you choose to compare apples to apples, irrespective of whether or not they're Granny Smiths or another type of apple, you'll find an apple.
I see. Well, that's very helpful. Well, Dr. McEvoy, I really can't thank you enough. I know everybody's going to be very interested in this because we do order troponins not anywhere nearly as commonly as adult cardiologists, but it seems like we're always, it seems a month does not pass that somebody comes in with dysfunction and gets a troponin, and maybe there's a wall motion abnormality, maybe not, and we're always debating whether or not that patient needs to be catheterized, and so having a better sense of what actual normal versus abnormal is extremely important, and I really want to congratulate you, all of your co-investigators, and I wish to thank you once more for joining us this week on the podcast. Thank you so much.
Thank you, Robert. If I could make a final point, an elevated troponin is myocardial injury. That does not mean that the patient had a myocardial infarction. I don't probably need to emphasize that to pediatric doctors, but certainly in adult medicine, it's an issue that keeps on coming up. And so myocardial injury can be caused by anything that stresses the heart.
And I think that's a very important point to end on for us in pediatrics, because it is rare that it is in fact an infarction, and there's much more likely injury in our business. Although I know in yours it's probably the inverse. So thank you for ending with that point. Very much appreciated.
Thanks, Robert.
Well, I think you'll all agree that we learned a lot about troponin levels and what the differences were between I and T, and also why high-sensitivity testing has superseded prior assays. I found Dr. McEvoy's comments on the benefits of using the 97.5% upper reference limit also to be very useful in better understanding the statistical rationale for his comments and suggestion. Finally, I think his admonition that elevation in these levels suggests myocardial injury, but not necessarily infarction, to be a point that we can all appreciate. I wish to thank Dr. McEvoy once more for joining us this week to discuss this important and sometimes confusing topic. To conclude this replay episode on high-sensitivity troponins, we hear the wonderful American mezzo-soprano Stephanie Blythe, who hails from upstate New York and is considered one of the great mezzo-sopranos of the past 25 years. She is the recipient of the prestigious Richard Tucker Music Foundation Award back in 1999 and was the youngest ever Opera News awardee. She has sung all over the world, and today we hear her sing the beautiful aria Cruda Sorte from Rossini's L'Italiana in Algeri. Thank you very much for joining me for this replay episode, and thanks once again to our guest, Dr. McEvoy. I'll see you all next week with a brand new episode.
Questo il premio di mia fe, non vi orrò che ne affanno, ma a quello in me. Tutti la bramano, tutti la chiedono, tutti la bramano. Da vaga femmina felicità, sì, 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 sì. Da vaga femmina felicità, sì, da vaga femmina felicità. Tutti la bramano, tutti la chiedono, da vaga femmina felicità. Tutti la bramano, tutti la chiedono,